ladies and gentlemen. Welcome to the final workshop of Pulse project. Pulse stands for Participatory Urban Living for Sustainable Environments, and it is a Horizon 2020 project that is ending in a couple of days at the end of April. We were all supposed to meet those days at the seminar in a sunny Barcelona, but for obvious reasons, we are meeting in the virtual space, in our virtual Barcelona, and it's great. We are so happy that so many of you were able to join us. I'm Karolina Mackiewicz. I work for the European Connected Health Alliance, an organizer of this webinar, and I will be your host for today. This means I will help you and all the speakers go smoothly through the agenda. Please make yourself comfortable. I have some small housekeeping announcements. So you can ask your questions to the presenters at any time using the question window in your admin panel. We will monitor it continuously, and we will ask your questions to the presenters when the time comes. We also would be happy to hear from you on social media. So when you are posting something on Twitter, LinkedIn, or Facebook, please tag the project. It's at Pulse Project EU1. With this, I would like to give the floor to Valentina Tegea, International Project Director at the European Connected Health Alliance, to introduce us to the webinar and today's agenda. Valentina?
Yes, Carolina, thank you so much for the introduction. I'm really glad to welcome all our participants today to the final workshop of the Pulse project, which is funded by the H2020 Research Innovation Framework Program. Personally, I have been working at the dissemination and exploitation activities of this project in the last years, together with the rest of the team at ECH Alliance. Just briefly, for those of the audience who might not have heard about our organization before, ECH Alliance is a not-profit organization which is working in accelerating and supporting the digital transformation of the health and social care sector. And in this project specifically, we have had the pleasure to collaborate with a group of 12 organizations, including the universities, research centers, SMEs, gathering many talented people and experts across 7 countries, and led by the Technical University of Madrid in Spain. So I'm not going to say a lot about the project because you will listen directly from the coordinator and from Pulse partners about its rationale, its objectives, and most importantly, what the project has achieved. But I would like to say just a few words about why Pulse and projects like Pulse are important and maybe get even more importance today. So maybe as you have read in our website, in all the information about the project that we have disclosed publicly, Pulse has aimed to make available a set of technologies, models, and tools to support cities and increase their capacity, especially the capacities of their public health organizations to better assess health risks and design more effective health promotion programs. And what we learned basically from Pulse along these years are that maybe 2 main things are at the core of health promotion. First of all, the need of enabling people to increase their control on their health and its determinants. And second, the need to foster a completely new approach to urban policy design, which is putting health on top of the priorities in the policy agenda. Indeed, in this context of the current pandemic, health has become the major concern for all of us and over all the other issues. So this will be most probably representing the turning point, which is going to make what we know as health in all policies, the future reality, actually. And in this context, of course, any kind of technological and scientific developments like the ones that Pulse has generated is becoming more important than ever before, because it's going to contribute to make a better use of data and to improve our capacity to modify individual behaviors, but also on a more upstream level, it's going to help informing policies that are affecting the overall urban population. So said that, I just wanted to recap for you briefly the agenda of today. First, as I said, we are going to listen from our coordinator and from other Pulse partners about the project and its accomplishments. Then after this part, we will open a time for questions. So please follow the instructions that Carolina has just given to you and type your questions into the systems, because we will read them aloud and we will try to get as many answers as possible from the speakers. And second, we will have a special keynote speech from the director of the Public Health Agency from Barcelona, which is also one of the cities that participated in Pulse as a test bed. And third, last but not least, we will go into a panel discussion with this fantastic speakers lineup that you can see on your screen and you already saw in our social media. And Carolina will introduce you better in a while. Even in this case, after the panel, please don't miss the chance to interact with us and ask questions in the system. As a very final note, I would like to add, as already stressed by Carolina, that in Pulse and in many other ongoing projects and initiatives, COVID-19 has pushed online communication in a way that maybe we wouldn't have imagined a few weeks ago. So we were, of course, using already virtual conferencing systems for our internal meetings. But now today we are relying on this technology also to experiment a new way to disseminate and share the knowledge that we have produced. And I just want to ask you to be a little bit patient if not everything will work perfectly. We do hope that the webinar will go smoothly and you could enjoy it and take the most benefit from these 2.5 hours that we are going to spend together. We have really done our best. And as a last note, I would like to say a big thanks to my team, to Carolina, Federica, and Bea for arranging and making a great effort in putting this together. Thank you so much and enjoy.
Thank you, Valentina, for this introduction to today's discussion and agenda. And let me now introduce you to our first speaker, Maria Fernanda Cabrera. Maria is working as Associate Professor at the Telecommunications School of Technical University of Madrid. Maria has been involved in European research programs since 1998. And in Pulse, Maria has been a project coordinator, and today will tell us about the challenge and Pulse vision. Maria, welcome to the webinar. Please join us. I see your microphone and camera is on, so please, the floor is yours.
Thank you, Carolina. Thank you, Valentina, for the presentation. Thank you, everybody, for joining this final project event. As Valentina anticipated, this project is ending at the end of the month, so in 2 days. In my presentation, I'm going to illustrate the different challenges that we have addressed in Pulse, the vision and the objectives that have guided us and led us to accomplish all the different results that we are going to share with you during this session and this final event. Over the last few years, digital technologies have transformed the economy and the society, affecting all sectors of activity and the daily lives of all citizens worldwide. Data is at the center of this transformation, and more is expected to come. It is evident that this paradigm shift towards a data-driven socioeconomic model has occurred as a result of this increased volume velocity and variety of data. In addition, powerful tools have been developed to collect, store, analyze, process, and visualize those large amounts of data. And in parallel, open data initiatives have been launched to provide broad access to this data from the public sector and the business and the science. It is clear that urbanization is still a leading trend, with more than half of the world population living in cities, and with that projection expected to increase. So citizens are an important determinant of the future sustainability for health and well-being. It is recognized that urban environments are playing a very important role in shaping health and well-being of the people. Some of the most important health challenges in these urban environments are related to noise and air pollution, lack of green spaces, inadequate transport, as well as reduced opportunities for physical activities. According to the latest air quality data, 97% of the cities in low and middle income countries with more than 100,000 inhabitants do not meet WHO air quality guidelines. However, in high income countries, these percentages decrease to the 49%. Nowadays, cities generate 75% of carbon emission that makes urban population the most vulnerable to climate change and the exposure to the different pollutants. Many citizens are exposed to high level of pollution, putting many at risk of long-term health problems. So citizens and cities are burdened by high level of non-communicable diseases, whereas the increasing incidence, earlier onset, and aging population in cities create a multiplier effect on these non-communicable diseases. Pulse address some of the major epidemiological challenges. As such, it covers diseases of the respiratory system that are one of the main causes of death in Europe and also worldwide. It's about 235 million people worldwide that are living with asthma, and studies are demonstrating that this traffic-related air pollution and childhood asthma occurrence is growing, and the ambient pollution exacerbates the asthma incidence. On the other hand, type 2 diabetes have been called the plague of the 21st century, with a lot of factors driving the increased incidence of diabetes type 2 due to this urbanization environment, the sedentary lifestyle in the cities, and the obesity. It's more than 80% of people diagnosed with type 2 diabetes are either overweight or obese. And moreover, there is a growing evidence that suggests that air pollution is a trigger of these chronic metabolic diseases, and emerging data from the different epidemiological studies are demonstrating and providing insights into the possible mechanics for this to happen. From all that we have, what I have said, it's clear that these urban environments are the prerequisite for having healthy cities and disease prevention. So health-focused urban design can roll back the epidemic of non-communicable diseases, making cities a bedrock for healthy lifestyles, as well as climate-friendly and resilient. So with all these, Pulse engage in a collaborative dialogue with a range of stakeholders across 7 global cities to transform public health from a reactive to a predictive system, focused on both risk and resilience. In terms of public health risk, as I said, we have focused on the link between air pollution and respiratory disease, like asthma, and between physical inactivity and the metabolic disease of type 2 diabetes, with an emphasis on environmental and behavioral risks of the disease onset. In terms of public health resilience, we have focused on well-being in communities. The goal has been to build extensive models that will be later presented and technologies able to predict, mitigate, and manage public health problems and promote community in health and cities. The main objective has been to create a new model of smart, healthy cities, harvesting big data from multiple sources across the city and beyond, open data, satellite data, and data from devices, wearables, different sensor systems to generate these risk models relating to asthma and type 2 diabetes, due both to air quality condition and the subject health status, and resilience models relating to the well-being in the urban environment. To do this, Pulse have contributed to a shift between the public health from a surveillance-based model or system to an inclusive and collaborative system via citizen engagement. Doing what? First, empowering citizens through a citizen science approach using the Pulsair app, mobile app, contributing to the creation of a urban health and well-being data set and enabling the creation of an observatory to assess city well-being and resilience, showing the impact of the pollution on health and the status of the citizens, fostering citizens' responsibility and awareness on air quality, and finally promoting habits that improve well-being and air quality. Pulse has also adopted novel methods for assembling and presenting big data on environmental and behavioral risk and resilience. Pulse analyzes urban databases, GIS data, sensor data, and citizen sensor apps to develop dynamic, interactive risk and resilient maps for specific neighborhoods in the 7 urban test beds. These maps and the different dashboards shared at the community level are available via the Pulse Health Observatories. This slide shows the 7 cities that Pulse have worked directly with. These cities are Barcelona, Birmingham, Singapore, Paris, New York, Milan, and Pavia, and can be defined as smart cities and communities that integrate different IT infrastructure and solutions and citizen service across different citizen sectors, including health. Here we have how the Pulse ecosystem has built on local initiatives, so it doesn't have started from scratch. So in each one of these 7 cities, Pulse have implemented or built on different initiatives. In the case of Barcelona, and you will hear later the representative from Barcelona speaking about how they have managed the COVID situation there. The local initiative was based on the development of Superblock as a response of the Barcelona Urban Health Challenge. In the case of Singapore, the local initiatives have been promoted mainly for the from the Health Promotion Board, like the 10,000 steps, and also the Housing Board Green Print initiative related with food and the healthier dining. In the case of New York, local initiatives, these are based on the prevention agenda for 2019 to 2024, based on different plans for the healthcare systems, the policymakers, and the citizens. In the case of Paris, there are different initiatives related with the alternative circulation, the sharing of vehicles, the bicycles, and also the promotion of public transport. Also, Birmingham brought some local interesting initiatives like the Clean Air Zone 2020 strategy and the different school programs. In the case of Pavia, the new network of air quality monitors were promoted directly from the city. And in Milan, in the same way than Singapore, the initiatives promoted at the national level are related to the 10,000 step challenges. All this work couldn't have been done without the participation of 13 different partners that have contributed with different unique skills. This is a picture of some of us. In some of them, some are missing, but I would like to thank all the work that have been achieved. And in the next presentation, all these that I have presented as a technology or as a model or as an initiative will be presented by my colleagues Manuel and Ricardo. Thank you so much.
Thank you so much, Maria, for the presentation and for building some fundament here for our discussion and further presentations. If you, the participants, if you have some questions to Maria, please leave them in the question window, and we will address them after the next presentation, after the presentation that is coming now from Ricardo and Manuel. We will take them together. So now I would like us to move to the content, to the flesh of the Pulse project, and introduce you to Ricardo Bellazzi, Professor of Bioengineering and Medical Informatics at University of Pavia, and Manuel Ottaviano, who is Senior Research Manager at the Technical University of Madrid. They both will tell us about the Pulse system, what is it and what services does it offer. Welcome, Ricardo and Manuel. So this virtual floor is yours.
Thank you. Thank you very much, Carolina, and thank you all for being here. So in our talk, we will try to give you more flavors about how the Pulse technology is being built, what are the basic components in order to try to achieve such a very ambitious goal that has been presented by Maria in the previous talk. So let's try to give you an overview of the architecture, starting from looking at what citizens currently do have in their mobile phones. We know that citizens nowadays are more active than what happened before, also because they really do like to have access to activity trackers and to apps that allows performing exercise. And moreover, some of the citizens are really interested in the environment. And some of the apps allows the connection with the sensors that download data about air quality, for example. Or there are many other apps that citizens are interested into that are really part of our view of what public health should be in the future. So on the other hand, public health organizations have a number of information available about the general health of the population, the macro phenomena, and at the same time, they can have access to data related to the air quality. That such data are collected typically by a regional agency that bring them into central repositories. So our first idea was to make a link between these two players in order to enable the design of a public health systems that engages citizens in the management of their health, also asking them to contribute to the data collection. Why we want to do this? We want to do this because the citizens can really provide information from their daily life at a level of granularity that is not available to public health organizations. On the other hand, putting together the data that are provided by citizens with the information that is available by public health organization really empowers the implementation of new systems, new models, new tools that can be derived from this merge. And what is very interesting is that once we have these models, we are able to provide feedbacks to both our major players of the game of public health. On the one hand, we can provide feedbacks to the decision makers, and in order to let them decide with a much better quality of information, more granular, more related and closer to the citizens. On the other hand, these models can run on each app of the mobile phones of our citizens and can provide them with instantaneous feedback. But we don't have to forget also that public health organization can also design intervention in order to be able to have an action that is more direct on the citizens, providing them with feedbacks, policies, strategies in order to improve the quality of life of the people. So that was the idea. And from the technological point of view, what are the components to do that? On the one hand, we have a new app that is delivered to the citizen that really allows to collect data in an anonymous format. And this app is coupled with the capability of collecting data also from sensors that can be delivered at home to citizens. Then all this information is merged and is collected together into a big data repository. And this big data repository is the other part, is the other component of our technology, is then accessible through advanced interfaces. Such interfaces are available on the one hand to the public health organization, putting together the GIS and so the geographical information system with the data mining system, data drilling tools that allows to go deep into the data. And finally, we have the models that are, in a way, pieces of technology themselves. In order to be able to reach to the maximum number of people and have gains from our technology, the idea was then to put in place three other interventions. That is basically to give surveys in order to favor the health in all policies, to start a collaborative dialogue with all the stakeholders related to this very difficult game, and finally to provide a course that we have called Big Data to Policy course that will be available on the web very soon. Now, let's go very briefly to some of the components of what I described to you before. So one of the key elements of the architecture is the availability of novel health risk assessment tools. As it was already discussed by Maria previously, we have concentrated our attention on two major problems that are related with the health in the cities, basically. One is diabetes and the other one is asthma. So the general architecture was the following. We have collected data from questionnaires and measurement from portable sensors and data from air quality. And such data are provided as input to two brand new models that have been developed within the project. Since we needed, in order to develop such project, data that has been previously retrospectively collected, we have resorted to two databases called MESA and ELSA that are very large studies that have been carried on in the past in order to be able to really build this new model on large numbers. And such two databases has been used and exploited to derive such models that then have been fed by the data collected by our citizens. And this model has been implemented in the two pieces of technologies that I previously presented to you. On the one hand, the app, on the other hand, the dashboard that is available to the public Health Organization. So we can go briefly to the models. In terms of the diabetes risk assessment model, this model has been learned and tested on both databases, MESA and ELSA, that have been used, and is basically a model that is designed to forecast the probability of a future diabetes type 2. And we have translated these probabilities into a qualitative score that is then shown to the citizen. And that, of course, is also used in the interface that the public health organization have. We want just to mention that some of the measurements that are collected are important or more important than others in order to forecast diabetes type 2 probability. And actually, the models have been smartly designed in a way because they can really work in 3 different scenarios. On the one hand, they are able to provide probabilities and risk scores in the case of the data are only collected through questionnaires. And this is the scenario number 1. Then if other information are available, something like waist circumference or blood pressure that needs measurement, but they are not invasive measurement in a way, it is possible to refine the prediction of the model in order to improve it. And finally, in case blood values exams are available, like fasting blood glucose, for example, then we can even have a further refinement of the diabetes risk assessment tool. So that's a very interesting tool that is now available with very high quality in terms of prediction capability, as you can see in the performance table. Together with the type 2 diabetes, we have also studied asthma. And in this case, the game was much more difficult because in the literature, there's much less information about asthma risk assessment. So our modeling group, led by the University of Padova, made a lot of effort in order to try to learn a model with good results. You see the results in the concordance index in the table. Maximum is 1 and minimum is 0, of course, but we need to be better than 0.5. Then you see that the model is able anyway to provide good information about the probability of future asthma. Again, the mechanism is the same, and in this case, in the same, it means that we have risk categories that are in a qualitative scale. And what we can see is that there are a number of variables that are important or more important than others. Some of those are really variables that are related to the environment, like traffic in the neighborhood, for example. And that's quite interesting because it includes information about the patient itself, the drugs he or she takes, and the environment around him. Then the third dimension that we have studied has been well-being. In this case, we wanted to evaluate 6 different dimensions of well-being: evaluative well-being, emotional, functioning, vitality, community well-being, and supportive relationship. Well, actually, all these dimensions are very important, and they can be, in a way, summed up to have an overall score or average in order to have an overall score of the well-being of a person. But it's very important to keep them separated. How this has been evaluated? This has been evaluated by our questionnaires that we have delivered to the patients. There are 8 self-reported questionnaires, and this data have been joined with the information coming from wearable trackers, the air quality sensors. And this is really I would say, a new game that Pulse had to deal with, and where we were successful in order to derive interesting results. As we can see in the next slide, we have the chance to measure or evaluate what are the items or information that are collected by the pulse systems that are more important for the overall score that can be achieved. And as you can see, we have anxiety and depression, and in general the health scale, that are very important to determine the overall well-being of the persons. A lot of analysis has been carried on in this area, and this is one of the most interesting results from the modeling point of view of pulse. You can see the correlation between the different dimensions, and also you can see in the results in the radar plot the differences between the answers in the different dimensions of the different cities. And then you can understand that the people perceive themselves and their well-being in a different way as a function of how the city is structured, and both from the social point of view and from the environmental perspective. I want just to mention that we had to collect a number of questionnaires. Many of them have been filled by many of our participants. We had around 1,500 people who participated to these studies. That's basically the story about our modeling activity. So we can move on to a modeling part that is, in this case, not directly related to the data that are collected by questionnaires, but rather to the data that are collected by the sensors. As I mentioned to you, citizens may have sensors at home that measures air quality. And thanks to these sensors, some of those are low-cost sensors, as the one that is presented here. These sensors can be put on balconies, for example, of houses, and they can measure every minute of every 5 minutes the air pollution in terms of particulate matter. And thanks to these kind of sensors, we can build a networks of sensors that is able to derive, minute by minute, a map of air pollution of a city. Therefore, by using the Pulsair app that keeps track of the localization of a person, each citizen can evaluate the quantity, basically, of PM that he has to inhale per minute when a certain path is followed. And as reported in the picture, in the simulation, we can estimate, for example, during one day, also as a function of the speed and of the activity, basically, that can be measured through the pulse system, we can estimate from the air volume per breath, the quantity of PM that has been inhaled. So this personal exposure model, of course, can be useful for each single citizen to have an assessment, basically, of what's happening and to try to answer to a number of questions. So maybe we can go to the next slide. And to put together this evaluation of their quality and of the personal exposure with the quantity of measurements that we have been able to put together, that allows to derive an assessment of the personal exposure. So on the one hand, we have been able to collect data and put together data in our big data repository that are available on air quality. And as you can see from each single city, we had the chance to import a huge number of different sources that contains information about air pollution. In this case, not only PM, but also all the other pollutants that are known to be very important from the air quality point of view. On the other hand, as I told you, we have been able to deploy devices in the patient's houses in specific locations that are of interest for the monitoring of the situation of the air pollution. And we have now a huge data source that contains both data that are sent from home, new data, integrated with the information that is available through different sources that are available as open data. We can move to the next slides and then ask ourselves what are useful for these exposure models. For sure, to provide feedbacks to citizens. So running on a single app, one can ask himself what is the retrospective evaluation of the exposure, something like what was my exposure in the last week, or to plan what is the best walkway from point A to B in the city. But of course, this kind of information is providing a huge source of important data to healthcare authorities and city council in order to understand what is the average level of exposures of the citizens, if there are changes between weekend and weekdays, at a level of granularity that is now not really available. We can move on then and to the next part of the presentation, and I think that it's the turn of Manuel.
Thank you, Riccardo, and good afternoon, everybody. I will, in the next part of this presentation, I will show you the technology that we developed within the context of the Pulse project. The first element is the citizen app that we call it Pulsair, that is available on Android Store and also Apple Store. This citizen app has been used in the project to contribute to the creation of this urban health and well-being dataset. So the main aims of this application is to foster citizen responsibility and awareness on health risk and also air pollution. Then also we want to show the impact of this factor to the health of the user, and we want to also push user to adopt healthy habits. So how we provide this type of services? We embed in our app a process that is based on 5 steps. The first step is to monitor, to get information about the user. The first, we are able to get information through questionnaire using the Fitbit data, and also if user want also to track the GPS data to understand the mobility around the city. Then when we have this information, we are able to assess the health risk, the overall status of well-being, and also to assess the exposure to pollutant in the city while the user is performing outdoor activities. Then when we have this information, we are able to personalize also the content to the user and provide tailored feedback and also specific information that may be useful and maybe also linked to local initiatives in the cities. And then after this part, we are able to push the user, to adopt healthy habits, and we make kind of monitoring of habits to try to push this behavior change. And then also through a gamification strategy, we are giving a reward to the user through points or through maybe also like using a dashboard to show the overall score in the cities. So in the next slide, I will show you, I will switch off my camera just to optimize the video demo. So I will come back at the end of this presentation with my face. So, okay, in this video you will see the registration process of this app, and consider that every city that joined our project may arrange some meetings with the citizen to ask them if they want to join, and the citizen receive a code that has been inserted at the beginning of this video, and part of the citizen also receive a Fitbit to be used together with the app to gather all information about physical activities. In this video is a quick video that shows you the registration process in which user need to insert this code and insert some profile information and also configure the wearable center. Once this process has been done, all this information is gathered and used to continuously monitor the user. So here you are seeing, for instance, the connection with the Fitbit devices, and that's it. So we support different types of health tracker. In the first one is sorry, wait, I have to switch off to my other presentation. So we support different type of devices like Fitbit devices, Asus devices, and also Garmin devices. So when we are able to get all this information, since we have this health risk model and well-being model, we are able to provide this feedback to the users. And here you see some screens with the specific feedback to the user and also some recommendation. For instance, you have here in the first screenshot the overall scores that the apps is able to estimate. The first one is a cardiovascular that we inserted because we consider also cardiovascular disease as like a very important disease, and so we import a model from literature. We are using the Framingham models, and then we will see also other 3 models: the asthma, diabetes, and the well-being model that have been developed in the context of PALS. So in the other screens, you see the different examples of feedback that we can generate for instance, for the well-being, in which we identify a situation in which the well-being is quite lower, and we trigger some possible content about to foster more positive moods, because in this scenario we have a user that reported to have a low level of mood and reported also some anxiety. Also, we have some content to promote some sleep hygiene, because also in this case, this citizen reported difficulties to have good sleep hygiene. Then we have also the other example for the asthma and for the type 2 diabetes. In the next example, I will show you how the feedback is given in for the type 2 diabetes case. So we have the app is gathering data. Time to time there are some questionnaires, and then when all this data set is complete, the system is able to estimate the risk. So here we have the last question that is more related to diabetes, but is also using other preliminary data as profile data of the user. And in this case, after filling this case, there is this estimation of the risk that is also available in the menu of the app, in which there are this feedback about the risk and also the available content that have been selected according to the specific profile of the user. So then we have another interesting functionalities that is the promotion of air quality and awareness. So we have different types of functionalities to make user aware about the condition of the air quality in the cities. The first one that you see in the first screens is about just to have, this is something also that is provided by many apps, to have an estimate of the overall air quality in a specific city, in a specific location. So in this case, we are able to leverage on internet services, but also on our sensor network that we deploy within Pulse project. And then with this information, in case that we are using also the information of the Pulse network, we are also able to show a specific map of sensors, as the case in Pavia, in which we are able to show the values of 40 sensors that we deployed in these cities. Then there is also a more advanced functionality that is the exposure estimation, in which the user will decide to track the GPS, to use the GPS position to track a specific outdoor activities, like a walk in a park, or like a walk in the center, or running activities. and start sharing GPS data to the Pulse system in order to have an estimate, and here you will see, of the exposure in the cities during this specific activity, like a walk, for instance. So let me just show you the video of this. So you will see in the app, now that we are here in Pavia, we can check the quality of the air quality, that in this case is based on PM10, and you will see that okay, we have good values of PM10, but not so good values of PM2.5. Then we will see the other layer of PM10 that is good, no? But also this index, I mean, depends on what type of pollutants the user will see. And then there is the case of the personal exposure, in which the user decides to perform an activity outdoor, okay, a work activity, for instance, and in this the GPS is starting sending data, and the user went out. So after like a while, when the user decide that this activity has been finalized and want to receive back the estimation of the exposure to pollutants, it will be possible to see in this map the intensity of exposure of different pollutants. Now you see the ones for PM2.5. Okay, and so let me back to, these are basically all the functionalities that we develop for the citizens. Now I want to also introduce you to the dashboards. The dashboards that have been defined together with the 7 test bed, following a process of co-design. And this dashboard has been designed for 2 types of user. The first user are the public health organization that will use these tools to make an assessment of the city and also of the population. Then also there are another purpose about research to have access to the full data set, to be able to make some statistic and comparison between different types of cities. We develop in this for the dashboard different types of functionalities. The first one that you see here is the overview, that is the initial page in which we aim to give just an overview of the data that have been collected in a specific cities. In this case, you will see the city of Barcelona, and you see on top the estimated risk of the model of type 2 diabetes, asthma, an overall well-being index comparing all the cities, also the air quality monitor for every cities. This is the case of Barcelona. And then you will see in the map the distribution of the participants of that are the user that use the app. Well, this tool is very useful in the sense that you can explore the data through the functionality that we'll show you later, but also it is possible to select a specific cohort of population depending on risk, for instance. So it will be possible to study the group of citizens that have been assessed with medium risk of asthma or high risk of diabetes, and for those it will be possible to add a specific intervention, as I will show you later. So this is the first functionalities. Then, for instance, you can select a specific cohort, and you can, when you select a cohort, you can then have this representation also in maps. Here you see, for instance, the cohort in Barcelona that uses the Fitbit data, and you see the
Manuel,
average.
probably you need to, we don't see the slides going on. We are stopped at slide 17, sorry.
Can you see my animation? Sorry.
No, not Manu, the moment. Maybe it's blocked. No, okay, now it's going ahead again. You are in slide 19.
What you see, what you would like to that I repeat? This, did you see these slides?
This yes, this yes.
Yes.
You see the dashboard?
Yes.
Okay, this was basically where we stopped.
The frozen one. Okay, sorry. Okay, so in this you see the a specific cohort of population of Barcelona that use the Fitbit tracker, and you see also the average of steps on a weekly basis. Then also it is possible through these tools to also explore in deep all the gathered data by classic dashboard analytic tool, and it's possible to explore social demographic data, lifestyle data, health status, neighborhood, the perception of the neighborhood from the citizen, wearable data. Here you see, for example, some result about perception of the neighborhood, about traffic congestions, fast food availability in some cities. And then you see all in this more advanced chart the distribution of Fitbit data. And you see, for instance, one interesting value about sleeping time, 6.5 hours, that is very in line also with the big studies about sleep performed also by the Fitbit. So then also regarding the analytics, it is possible to use geospatial analytics within Pulse. And these types of tools are very powerful, because if we are able to show the map, two maps at the same time in the same window, it will be possible to start making kind of visual correlations. For instance, here we have a map of New York, in which you see on the left side the poverty rate, and on the right side you see the hospitalization rate. So we see that when poverty rate is higher, there is also higher hospitalization rate. At least it's happening in this zone of New York. Then also it is possible, for instance, to use through the geospatial analytics also satellite data, and correlate, for instance, heat map, as you can see on the left side in this a map that represents the heat of the city, and on the other side, on the right side, you will see NDVI index, that is an index that estimates the amount of vegetation in a city, and you see some correlation now between parks, like for instance here we see Central Park, you see other parks here, so you see how this type of information can be correlated, and also then how the presence of green parks is essential in the cities. Then also, for instance, you can also have the same map but a different moment of the year. And also in this case, you see the pollution level in New York in summer on the left side, and in winter on the right side. So geospatial analytics are a very powerful tool. Then also there are another very, very interesting aspect of this geospatial analytic tool, that is also the possibility to use this the temporal data of a specific of a specific information. For instance, here we have the map of the sensor network of Pavia, and we are able to navigate through this sensor network and see all the statistics over time, to filter the data by day, by hour, by month, and to also aggregate different types of variables, and also to export this data to make a further processing. So now you will see here, for instance, that you can select different type of metrics for every sensor. You can download, and you can use it. So it's a very advanced analytic that show the change in situation, not only in a geospatial way, but also in time series way. So let me go further. And then we have also simulation tools. In Pulse, simulation tools are tools that show the temporal, in this case we have this tool that show the temporal evolution of the asthma hospitalization. In in this example, we focus on a specific area of New York. It is the same that I show you in the map before, the place in which we have higher hospitalization rate in New York. That is East Harlem, and we use this case scenario to start studying asthma as a multifactor case in which there are some individual factors, okay, the physical condition individual, but also some environmental factor and social demographic factor. So in this work, we create a tool in which it's possible to simulate the traffic density, the speed of the car, but also the industrialization percentage of land used, and also the recycling rate as also environmental factors. Then also we have some individual factors that are the obesity and also the age of the user. And through this tool, we are able to navigate to make an estimate over time. Okay, how now you see this simulator that is running, you see the simulation of the cars moving in the city. You see here on the right corner, this is the output. These are the healthy people, and this one are the people that has been hospitalized. And you see how changing, for instance, reducing the industrial use, you should reduce the emissions, and also population will be healthier. And you can see also that this happens if you also increase the recycling rate. Okay, you see, look at this part of the screen, the population status. And if you, for instance, increase the obesity rate, also the hospitalization increase. So these types of tools, we think that these types of tools are very, very useful in this, because it is possible to simulate variables that are coming from different type of sources, and also will be a very interesting tool to assess different types of policies, because if you see in this example, we have traffic and speed of the car, that maybe this decision should be taken by the Department of Transport. Then we have some other variables that are in the industrial use and recycling rate, that it is more related with urbanism. And then we have obesity, that maybe is more linked with health. So we all together, this department could work together in a simulation like this to understand what would be the best policies that could impact the health of the individuals. So then we have also another, this is the last tool for the dashboard, that since we provide an overview, we provide also these analytical tools, and we provide simulation tools. Okay, then we think that with these tools, we are able to give an idea to the policymaker and the public health organization about the situation. And what we implement is like a service to trigger specific action to the citizen. So what we developed as a system is another functionality that is able to send and push content to the citizen app from a web interface used by the public health organization. So let me show you just the example. This functionality has been developed to foster, for instance, physical activity in the city, to make user more aware about pollution, to make a poll, or also to send specific message to a specific cohort of population. In this case, we have the example in which we have this decision from the public health authorities to push, to promote the reduction of type 2 diabetes risk, by sending educational content related to how to manage this risk. So in this video, we send this form that has been filled, and in this form, all this content has been set up to be sent to the app, to the citizen app. And now we are back to the citizen app, and you will see how this message will come to this app. That is, the user of this app is a user with high or medium risk of diabetes, and we receive a specific educational content. So we are able to tailor, thanks to our health risk model, we are able to also assess and also to stratify people, and also targeted specific messages and content. Sorry, but
Manuel, how are we doing with time?
Yes, I have just 2 slides.
Perfect. Thank you.
Then, okay, so these are the main tools for that we develop in this project, that are one for citizen and the other for public health organization. But then in order to maximize also our knowledge and the impact of what we really create, we create a community of practice that is a collaborative web platform in which we share the experience and the knowledge that we acquired during the course of this project. So you can access to this community of practice by going to the web page of Pulse in the testbed section, and you will see that there are detailed information on every city that joined this project. Then also, and this is the last activities that we perform, we also create a specific digital course that is for free, accessible to everyone. And it is a multidisciplinary online course that share the experience and also the backgrounds that have been used to create this type of research. So it's a very multidisciplinary course. We have like more than 10 professors that joined this course. Part of them for sure are part of the Pulse consortium. And we started with some more topics related to public health, challenges in the cities. We describe also some theoretical part about social determinant for health in our policies, and then we will start giving also some technological background related to smart cities, big data, also about the opportunities of and methods of artificial intelligence. We have specific seminar about health risk models and the well-being model that have been produced in Pulse. Some also specific lecture about geospatial analytics, and then also some specific information about citizens, a solution like mobile app, and also the approach of citizen science, to then finalize with ethic and regulation. So this course, description to this course are open. You can access again from the web page of the project. There is a learn section in the menu, and the course will be, the inscription are open, and now we are going to go live. I think the next week we are just finalizing the shaping of all the content that we collect. Thank you, everybody.
Thank you so much, Manuel and Ricardo, for your very comprehensive presentation. I think we learned a lot about the Pulse, and also you showed us so many different tools that can be used, and certainly the online course. This is something that many of us can now take. You know, like as the e-learning, of course, the popularity of e-learning has increased. So let's see how this will also influence the intake of the course. So thank you. And now we have some 10 minutes for questions and answer session. I saw that there are several questions posted by our participants, and I will now pass the microphone to Valentina, who has monitored the question window and has picked up some for you, Manuel, and Ricardo, and then perhaps also for Maria, who presented before. Valentina?
Yes, thank you, Carolina. Okay, I don't know if you can see my cam. Okay, great. So yes, we have a number of questions. I will try to group some of them which are similar, for instance, about the ownership of the data collections and how is the data stored and maintained, also not only during the project, but also after its completion. First question, for whom of you would like to answer? Manuel, maybe?
Well, in terms of ownership, I can say a few words, then I leave to the technical maintenance to Manuel. In terms of ownership, it's clearly the citizens who owns the data that are put into the repository. Then, of course, there is a consent of using the information, of using the data in an anonymized way. That's the way we store it, by the way, and aggregated in order to for the benefit of the public health observatory. So that's the principle behind the data collection.
Thank you very much, Riccardo. There is also connected questions related to the possibility of the devices to provide data for medical specialists, and if so, how?
Well, it's again me, no. The idea in this project, we are not providing, this is not a system that is thought to be related with the healthcare of the persons and the connection with the healthcare specialist. The idea is to provide a feedback to the two players that I have shown in the architecture, so the citizen and the public health organization in terms of general risk assessment process, but there is no direct link with clinical care or clinicians.
Wonderful, Riccardo, thank you so much. There is also a question related to the well-being model and how the questions that have been developed relate to the ICF of the WHO, or if they are using any other international standards. Manuel, we cannot hear you. I don't know why.
Okay, so we are basing on the European well-being surveys. We use this as our gold standard, and in this survey we have 6 dimensions. So we focus on our gold standard is this one. Can be related, some dimension can be related also to the ones of the World Health Organizations, but I think that is quite different, because in not just focusing on health and all these individual factors, but also some external ones.
Thanks again. We do have also a question about the availability of the course, of course. So there are quite a lot of attendees that are asking when and if they will be able to access the big data to policy course. Thanks for the question. Of course, it's going to be online, I mean, in few days, and we will publish the news on our social media. So please continue to follow us. Then there is also a question about what platform has been used to create the dashboard.
We used Glassfish. Okay, so the Java server, like for all the infrastructure, PostgreSQL, and then the dashboard has been used using Glassfish and some also chart libraries based on JavaScript. But it's almost Java for the backend and JavaScript for maybe some advanced visualization.
Wonderful. Another question about future plans. So do we plan to make the app available to more people and more cities? And the second question related to this is when a new city is added, do we need to train the algorithms again, or those used for some cities can be generalized, in your opinion, to work with other cities? Quite interesting question.
Health risk model should be support also the cities, because they have been calibrated in an external data source that is more extensive, so they should work. They should work the health risk model. Meanwhile, as also the result highlight of the well-being models, I mean, on that we should see, because we have different behavior in different cities, and this is, I mean, the results of different culture, different cities, different level of organization. So for the well-being, this will be different, because we think that the well-being model will work in different way in every city. Meanwhile, the health risk model, yes, this is a thing that is.
They have been designed on. They've been designed on an external data set. They are exactly designed to be exportable in any city.
If I can add to the answers about the new cities joining the project, I have to say that in fact we started with 5 cities, and during the course of the project we added 2 new ones, and we are working towards the addition of Madrid in the near future. So this means that we really want to continue the work that we have initiated, and now even with the new situation of the COVID, trying to adapt some of the tools we have used to really try to provide some of our knowledge to the solutions or to the of this pandemic. So yes, if any other city is interested, please contact us, because we will be happy to get you on board. Thank you.
Thank you very much, Chiqui. There is also another question about the number of the users who have been using the hub so far.
More than 1,800 people, I think, if I am not incorrect.
Okay, great, thanks. There are also some offers to collaborate further and connect with other projects, so we will get in touch for sure. Thanks, Lisbeth, from a Dutch project about ICF for disabled people, and we will get in touch with you soon. There is also some attendees asking if we will make available our slides. Yes, of course.
Yeah.
They will be in the website, and they will be also published in the social media. So I think that I have more or less gathered all of them. So thank you very much. It has been a really nice interaction, and I think that we can go ahead, Carolina, with our next slot.
Yes, thank you so much. Thank you everyone for asking questions and for answering questions. And with this, we will move to our keynote presentation. Joining us from Barcelona, Carme Borrell, who is the Executive Director of Barcelona Public Health Agency. And as you see, the title of the presentation of Carmen is Robust and Dynamic COVID-19 Data Analytic Platform for Barcelona. So this is, of course, something very timely when everyone around the world is looking for data to inform policymakers, to inform us all what is happening, what is going to happen, and how actually what should we do and what should happen in our cities and in our countries. So I see Carme's website, I see Carme's screen. So with this, I would ask Carme still to put her camera on, if that's possible. And yes, we can see you. And so please, the floor, the virtual floor is yours, Carme. Welcome. We cannot hear you.
No? Yes?
Now we can hear you. Perfect. So I will switch off, and as I said, the floor is yours, please.
Thank you very much. I will present now our website that we have just built these days in order to monitor COVID for Barcelona city. And I think that this can be also useful for you, because Barcelona is one of the cities that has been in the project, and therefore I think that this is not so different that what has been shown in some parts. This website has these 5 parts. The first part shows the the cases, the diseases that have been diagnosed in the city by the PCR test. As you know, or well, I can explain you, in Spain, in Barcelona, to have a test is not so easy. It is difficult. Therefore, we have tests mainly for people who have an important disease, then people who are in the hospital, not those cases who are just in primary health care. And then, as you can see here, we have 13,300 for Barcelona diagnosed. And then the first part of the website is to show these cases, then to show the cumulative incidence, that is the cases divided by the inhabitants of the city. And then I will show you some results of mortality data and cases diagnosed in the primary health care. This case, some of them do not have the test, the PCR test, but they have been diagnosed by the symptoms. And finally, I will show you the socioeconomic data for the different areas of the city. Well, here you have the big numbers, 30,000 cases, 2,500 of them have been diagnosed in nursing homes, as I suppose as you have seen in the press, because it's the same in many European countries. Nursing homes have had an important problem with COVID. And here you have the incidence by 100,000 inhabitants. This is total men and women. And here the incidence without resident nursing homes, sorry. And finally, the number of deaths that are related with the COVID, that are 3,000 more or less. Well, you can see here, here is the number of cases through the different days. You can, here for one day, you can see the date and the number, 10,000, and you can choose the age groups. For example, now you are seeing 3 age groups. For example, 2 age groups. You can also choose the sex. Then it's age groups and sex. You can say just, I only want to see total. Yes, total by sex. You can see here men, then women, and then total. And this is increasing through the days from March 12 to now, and you can see how it's increasing each day. Also, you can show in linear scale or logarithmic scale, well, as you prefer, linear. The next one, you see the number of cases by each day. This is increasing until March 26th and then decreasing. We don't know what happened yesterday here. We have to analyze if there are probably nursing homes, but we are not sure. We have to analyze because this is not normal. But as this tool is updated every day, we can find things that we have to study more. And again, you have age groups here, and you can, I don't know, for example, more than 25 or more than 65 to 74. And then you have for women, and then you have for men, and well, you can see. And here is the distribution by sex and age. Here you have the numbers and the percentage, the different age groups. Here you have the number, you can put inside you 621, and this is 12% for men. And here for women also, you have the percentage here. And then you have the number of cases in the neighborhoods of Barcelona. And the different neighborhoods, just the number of cases. These are not by population. These are the numbers. Okay, you can change also men, women, and also the different age groups, same as before. And then in cumulative incidence, this is the number of cases divided by the 100,000 inhabitants. And again, it's increasing, and you can see, for example, women, men, not total. And you see the numbers are men, and now we have more women than men. It has changed through the days. And these are the rates, not rates, but cumulative incidence divided by population. And then we can see that for men in the age group more than 75 or 65, 74, you can see that men have higher rates than women. And this change in the youngest people. Then we can see difference by age. And also these are rates by neighborhood. And you can see standardized, age standardized here, and no standardized. And if you don't standardize, you can choose age groups. For example, you can choose age groups. Neighborhoods change by age group. Yeah. And this is total, standardized. Okay. Okay. And then you can see here by socioeconomic level. These are 5 socioeconomic levels. This is the here is the highest deprivation, and here is the lowest deprivation. And here are census tracts of the city. We have 1,000 census tracts, and they are put together in 5 groups depending on this index of deprivation. It's an index constructed with many indicators, and you can see this is without standardization, this is age standardization. And if it's not standardized, then you can have different age groups. Yes, you can see here the gradient. The rates are increasing when you go to the lowest deprivation for men, and not so clear for women, but also you can see some gradient by deprivation. And then you have another map here. This map is with census tracts. And you can see also by age group, men, women, sorry, for men. Okay. And then for age group, for example, more than 75 here, well, you can see the small areas, and you can go there and analyze more what is happening here. Well, you can go inside the map and looking the difference inside the map. And then you have another map by census tract also showing you the probabilities that this census tract are highest than the middle of Barcelona. And here the probability is 90%. Then you have these maps, these tracts that are in blue color. They have a 90% probability of being highest than the average of Barcelona. And then again, well, this is an epidemiologic measure, the risk relative. And here it's the risk relative related the association between deprivation and incidence of the disease. And you can see again how this is increasing, here a little bit decreasing, and you can choose 2 measures of socioeconomic status, and then sex, and then age group. You have the risk relative and also the 95 confidence interval. Here you have mortality data. This data has been analyzed by the burials because we don't have the mortality register just so quick, and we use variables in the city. Here you have the number of expected deaths following the deaths observed in the last 10 years with a 95% confidence interval. And in blue color, you have the observed deaths. And here below, you can see that during this period, there have been almost 5,000 deaths. And our expected deaths were 2,000. Therefore, the excess number is almost 3,000. As you see here, 2,939. And you can see how mortality has been increasing for each day. You have the data, you have the number of observed cases, the number of expected cases, and then the excess of mortality. And also you can see this by age group. And also you can see that for male and female, again, as has been seen before. Well, I think the website is updating, but okay. Here is the percentage of excess of mortality. Again, men, women. For the more than 75 age, you see that there are more women than men with an excess of mortality for this age group mainly. And these are the rates, mortality rates. Again, when we compare the excess number of deaths divided by the number of inhabitants, we can see that the rates are higher for men than for women and in both age groups. Here we have only shown more than 65 because the majority of deaths are related with being old. And finally, this is well, it's not the last, but finally are the cases diagnosed in the primary health care. Here we have the cases that have been diagnosed with the test, PCR, the same cases as we saw before. But here you have the other cases that are not diagnosed by the test, but they are diagnosed by the symptoms. The physicians say that they have the COVID, but they are not able to do the test. Therefore, they are just possible cases. And here you have total cases. And then you can see that when we look at the possible case, they are 3 times those confirmed cases. And also, we don't have here cases that have no symptoms because nobody knows who are them, and we don't have analysis of seroprevalence. But in the future, we hope we'll have. Again, you have sex. Again, you have age groups, and then you can choose here if you show all cases that are diagnosed, possible, or total. Well, you can see different possibilities. And finally, this is the map. This is the map for the primary healthcare teams. In blue colors, the ones we have data. In gray colors, the ones we don't have, because it's not possible to have for all of them, but it's possible also to see the maps. And in this case, are not neighborhoods as before, just are primary healthcare territories. And finally, you have the distribution of 2 indicators of socioeconomic or income. For example, here you can see this is the typical of Barcelona, that this is the parts of Barcelona in blue color who have the highest deprivation. And in the other one, here we have just the opposite. No, it's the same. It was the opposite. It has been changed. Yes, you see that the distribution is more or less the same. And I think that's all. That's all what I wanted to show.
Thank you. Thank you so much, Carme, for your presentation and showing us what are you working with. And it seems very impressive and, in fact, robust, like the title of your presentation was. At this very moment, we don't have time for questions to Carme, but if you, any of our participants, would like to ask Carmen a question, please post it in the question window, and Carmen will be available to answer the question together with our panelists. There was a question already if the website is available, and yes, it's on, and I know that Valentina was answering this question. So thank you for your interest in the work that is being done. And now, without any break, but hopefully with a good cup of coffee or tea, we will a bit switch the gears and move to the panel discussion to explore with the external experts the topic of data for population health a bit more. I think the Carmen presentation was ideal to actually also to put us in the mood. To show us how the data, the big data collected is important. Actually, it's important every day for taking very important decision about the people's health. And we have with us 4 experts from different countries, from different sectors, and from different professional backgrounds to explore with us together how data is changing the way how decisions are made in large public healthcare systems. Our moderator today will be Jose Pagan, the professor and chair of Department of Public Health Policy and Management at the University, New York University. So Jose, please tell us how what will happen now and how we're going through the panel. Thank you.
Thank you so much, Carolina, and welcome everyone to the panel. Let me. So I'm very honored to be moderating this panel discussion on big data and the future of population health. We're experiencing fast-growing use of digital tools, technologies, predictive modeling capacities, and the amount of data to improve health. These massive amounts of data are increasingly available, and they're being used to make decisions. You can look around online and you'll find data and tools to address many health conditions, like the tools that we have built. The use of data by policymakers, citizens, researchers to address the COVID-19 pandemic is evident everywhere in the world. But there are also many challenges to link technology and data to improve health. Pulse was able to address some of these challenges, but also struggle with others. We struggle with how to address data consistently across cities and countries, how to address differences in data privacy laws across countries, and how to think about variation in the amount and accessibility of data available in each city. There's also the issue of how to make the data useful. In New York City, for example, where I live, data are available for testing, positive case results, hospitalizations, deaths related to COVID-19 at a really granular level, neighborhood level, like the data that you saw from Barcelona. And tools have been built by many citizens and experts to visualize this information, but sometimes analytical needs, data needs, they center on monitoring, for example, intensive care unit bed utilization, health system capacity to manage COVID-19. So we need to have mechanisms to link all of these types of data and sort of like differences in use and need. So let's hear from our speakers, their perspectives, from the perspectives on Pulse, big data, technology, and the future of population health. So we have 4 speakers. Our first speaker, and the 4 of you can turn on your camera, is Joe Ivy Buford, clinical professor of global health at NYU, at the NYU School of Global Public Health. We also have with us Elizabeth Bengston, consultant with the WHO Healthy Cities Network. Tom Kirchner, he's the director and PI of the mHealth Mobile Health Lab at the NYU School of Global Public Health. And Fiona Donovan, project manager of the National Healthy Cities and Counties of Ireland at the Health Service Executive. So let's begin with Joe Ivy Buford. The floor is yours.
Okay, thank you very much. I could have up the first slide. I don't know if I'm controlling it or someone else is.
I'm controlling it.
Perfect.
Yes, so,
Thank you.
The floor is yours, and as we agreed, you will have 4 minutes for this intervention.
Okay. I'm presenting. I'm really delighted to be invited to be part of this panel, and the perspective I'm going to bring to it, I think, is of the International Society for Urban Health and work we've been doing over the last decade or more to really work with the global health policy community to get across the importance of urban health. And so this is coming back to about a 30,000 foot level to put this in context. And the Pulse project is extremely exciting and very important to really show progress in being able to move the concerns of the urban environment and health together and into the policymaking process. So let me start by, yes, this diagram. I'm going to talk to you. I know these are a lot of experts on this phone, but I want to talk a little bit about where policymakers are often starting from and where communities that aren't into the exciting work you're into are thinking about it. The first challenge we've had is really letting people know in global presentations and others that health does not only mean healthcare. This is a really important issue. This is obviously an iconic diagram that shows the various determinants of health, starting with the inner circle of individual factors and then moving into the families and communities. And clearly the policy environment in cities that we've heard about so far today that affects the healthy conditions or the unhealthy conditions in communities that people live in. Next. Just push to, that's great. This is a diagram we've been using in the International Society for Urban Health to sort of try to help people picture the multiple determinants of health. And you can see that the health sector, healthcare sector in the red is one component, but it's very new for people to be thinking about the importance of the issues you all are raising in your presentations among policymakers and political leadership. So areas that you're covering very intensely, like the natural environment, air pollution, built environment, transportation, urban planning, community cohesion, and obviously governance are all important factors. And the message we're trying to bring across is that decisions made in all of these sectors may probably in the aggregate, certainly in the aggregate, have more influence on the health of individuals than their access to the personal healthcare system and the healthcare system. And I think the recent focus on COVID has probably shifted the policy focus to hospitals again. But I think Dr. Burrell's comments are really, really important in showing the context in which healthcare delivery and case incidence is present. Next. The global community has really taken on the issues of cities in the SDGs. This is the first time that the urban environment has been included in a set of global goals. These are the elements in Goal 11. Goal 3 is health. We usually think about that, but we need to think about Goal 11. And if you look at all of these characteristics, they're all things that the previous speakers have talked about and that are in the control of political leadership, especially mayors at city level, but also at national level. But you do not see the word health mentioned in Goal 11. This is a partnership increasing happily between the UN Habitat Agency and the World Health Organization to bring these two elements together. But the work that Pulse has done is really exciting because it takes for granted that one has to deal with the healthcare system and the other sectors influencing health and connecting, collecting the data from those and connecting it together. Next. This is also a huge paradigm shift for the global health community and health policy community. On the left-hand side of this slide, you see pretty much the areas that have been focused on in what I would call the medical model, the WHO model, which has been historically more diseased focus, which is how do we strengthen health systems, how do we have an adequate healthcare workforce, and how do we get essential medicines to individuals in the community and in countries and the cities. This is still, all of these areas are still huge concerns. Health system strengthening now is being talked about in the context of universal health coverage, But on the right-hand side, you see the introduction really of something new thinking in terms of creating healthy conditions in countries and cities, which is the kind of cross-sectoral model, health in all policies model that that the Pulse program has really been talking about. So this idea, I think the important links that you've made in this is to identify the variables that create conditions in communities that influence health. You've talked about air quality, you've talked about diabetes. We now know that these conditions in communities that influence these illnesses are enormous pre-existing conditions to exacerbate pandemics like COVID. There's also the need for integrated models, and in our work with cities, I think the biggest challenges we're finding is obviously the availability of data systems. By showing 6 cities that are doing this in real time, it's going to be very important. Secondly, big challenges in collaborating across agencies and across sectors within government, and as well as with government and civil society and the private sector businesses. And finally, the political leadership to bring sectors together and engage with communities to advance the concerns of urban health. And let me just end with this last slide, which is the next challenge for Pulse, if you will. I mean, one is spreading what you've learned already in high-income countries with these capabilities, but this trend of urbanization is really fastest in low and middle-income countries. And I think the challenges of adapting the Pulse findings and results to these low-income countries is critically important to achieving global health. Thanks very much.
Thank you. Elizabeth? You're next.
Yes, thank you very much. Thank you for inviting me to this very exciting seminar. And I'd like to invite you to my home here in Sweden. I have been working with the Healthy Cities Network for many years. And I would like to, first of all, congratulate you to a very exciting and interesting project. I find this, the presentation you just made extremely interesting, and it will be very interesting for the network of Healthy Cities to take part of. So can I have the next slide, please? Thank you. Just a few words about the Healthy Cities. The European Healthy Cities Network is a network that's been going on for more than 30 years. And this is something that Fiona also can talk about, I think, later on today. And right now we are heading into the next phase, the phase 7. And that means that we have committed ourselves to 6 core themes. Because this network is a commitment made by city leaders, by city mayors and city administrative resources throughout Europe. And we have about 100 cities directly engaged with the WHO in this network, and about 1,000 other cities that are more or less indirectly engaged in this. And for this next phase, we are talking about investing in these 7 core themes, and they are built upon people, places, participation, prosperity, peace, and the planet. And as you can see, these are our commitments to the determinants of health, to health equity, and to sustainable development in our cities. So can I have a next slide, please? Yes, so if we want to have commitments and work towards these goals, we need to have robust data on the local level. So listening to this Pulse project really encourage us to see that today we can find local data. Normally we've been having data maybe from our national levels or our regional levels, but today with new technology, the sky is the limit for the data that we can collect on our local levels. But having said that, and coming from a country where we have had population statistics since the 1800s, I would say that we do have some challenges And we do need to have some concern about how we collect the data and how we use the data. Because if we want to have a local trust and participation from our citizens, we need to also think about how this trust is going to be built in how we use the data and why we are collecting the data. We need to be very clear, I believe, on the purpose of collecting the data. What is it used for and who is going to use it? Is it nice to know information, or is it need to know information? We always talk about this is bringing a better health to our population, but we also have to think about if it's a common good, or is it that something that goes against the personal integrity of, do I want everybody to know my medical status? Do I want to put everything into an app that everybody else can understand and get information about me? So do we need to be a bit careful about how we use it for the common good? And a recent issue that has come up is who owns the data. I know today that several of the big companies like Google, Facebook, and others have come up with suggestions for offering, for example, the Swedish government to be supportive in using data of how people move about and how this new pandemic is spreading. But who owns that kind of data? And do we want the public service to own our data, or is it private companies who actually owns the data when it comes down to it? And I think that's another issue to be concerned about when we talk about our populations, and that is the issue of health equity. Because as you found out in Barcelona, there are some huge differences in our populations. And we can see socioeconomical situation, for example, being one of the differences. So before we start collecting, we also need to know who can access and participate in giving away the data and use the data. We have different populations that we know are not reaching their potentiality in their health, and we need to be very careful about how we then continue with collecting data. Are they within that kind of population that can actually access it, or are they not? We always think that everybody has a phone today, but that is not true. There are populations today, and there are people today that don't have a phone and don't know how to enter the data into an app, even though it looks like everybody has it today. So there are pros and cons with big data and the local level. And I would say what we can do right now is to listen and learn from this present pandemic and this present situation. Because I've just had a conversation with lots of our cities in Europe. And in nearly every city, every country, there is a fast development today of apps and databases for finding out who has got this disease and who hasn't, and trace people. So I guess there will be a lot of innovation going on, and I think we can learn a lot of what is happening right now and see what works and what works for the entire population and what works to achieve a sustainable development at the moment. So I guess that is what I would like to share with you right now. Thank you.
Thank you, Elizabeth. Tom, you're next.
Hi, everyone. My name is Tom Kirshner. I'm an assistant professor in the School of Global Public Health at New York University. I'm the director of the mHealth, or Mobile Health Lab there. It is an honor to be here. I appreciate the invitation greatly, and it's been a pleasure to learn about this project. I feel like I'm a little late to the game here, of course, but I look forward to learning more and perhaps collaborating. So if you could advance to my next slide, please. I want to start with the problem of ecological complexity. the title isn't showing up. I can't remember if it's animation or not, but it says ecological complexity on the top normally in the slides. So you're not missing much. All I want to say here is that while, of course, we're awash, as others have pointed out, with very useful organizing frameworks, I would say that, for instance, in the one presented here, this is from Tom Glass and others from Hopkins a few years ago, help us lay out all the factors that we think might be in play. So here you've got a case applied to cigarette smoking with the little purple circle in the middle there. And you can think about all the contributing factors above and below the skin and unfolding over time. These are useful organizing frameworks, but they are not fully yet able to capture the type of complexity we all see within urban systems and believe there's a lot of potential with. You know, what's exciting about Pulse and other, what I would call geographically, temporally explicit systems like this, is the ability to operationalize these systems and truly start to study these in a theoretical, predictive, and testable way. I think the first thing I want to say, though, is that I think we need to be careful that we adopt a problem-focused approach, right? And not get lost in the trees of our own basic science details. There's a ton there that's really interesting. It's a reason why a lot of us are here. But on the other hand, we need to come back out of the rabbit hole, as it were, and make sure what we're doing is communicable to decision makers and so forth. So let me go to the next slide, please. I want to add to this discussion, I want to mention a resource that we've developed in my lab. This is an engagement tool. Essentially, this is connected to a couple of National Institute of Health, US NIH grants that are intending to understand the connection between people and places. When we think about mobile health, we're really talking about that explicit connection between people and places. I don't have any time here, but we've got a bunch of information. If anybody visits this site, in the About page, talk about some of the scientific underpinnings, mostly having to do with how we think about boundaries. And what we're trying to do here often, in the most general sense, is disentangle and understand the predictive utility of, in the first place, addresses and conceptions of home and neighborhood, and the additional information we can garner from understanding individual experiences, the course of the day, multiple different neighborhoods, perhaps, things like that. I think what I want to say, though, again, trying to bring this back, is that while we want to develop this technology and the fancy methods that are required to do this disentangling, we want to remember and not throw out the baby with the bathwater, as it were. It's my understanding that census tracts and address-based metrics are here to stay, right? Cities, municipalities are going to continue to need to rely on these sort of aggregated perspectives on their municipalities. And so the goal isn't to just develop something fancier to throw out the old. This is the way I think about it. What we're trying to do is to take the information that we gather and enrich what are already existing systems, administrative boundaries, et cetera, so that, for instance, when the city asks, where is the food desert or something like that, they can rely on estimates that don't just take account of the boundary. This is sort of what we might call the fishbowl model, the idea that the only food you have access to is within that little boundary that happens to be drawn around your address, and the idea that food access has more to do with an anchoring effect, right? The implications of living within that boundary have to do with the time and effort you have to spend to venture out into the area around you and access ingredients that you like and bring them back home or eat out. So can I go to the next slide, please? This is my last one. So as we consider the potential for the distributed societal benefit of these type of systems, I want to mention another example. My lab has been funded by the National Science Foundation on a COVID-related surveillance project. And I can't go much into this one either, but I just want to say a couple of things and tie it back. The essential idea is that we're trying to collect perishable data, quote unquote. We often think of street views and map data in a fairly static way because it can be tough to collect. And what we're trying to do here is to collect data around medical centers in New York City longitudinally every day to get a feel for some of the temporary shelters, where are the emergency room entrances, et cetera. We have field workers using Mapillary application and OpenStreetMap resources. You can see an image here taken by maybe you can see it, by a team member. And this is an ER entrance for a, I think this is one of the Langone centers in Brooklyn. And this sort of technology can connect a small group of field workers in a small area of a city to the cloud, where other individuals can go in and annotate this information using OpenStreetMap tools, if you all are familiar with those. So I want to tie this back. For me, this highlights the way small numbers of people can contribute in ways that benefit many, right? And when we think about how systems like Pulse can have a positive impact, I think it's really essential to go back to what we've heard about today in terms of how it integrates the well-being aspect and the role of measuring experiences among the people who are part of these systems. In my world, this goes back to a concept we call experiencing sampling, going back to the late 1970s and 80s. And so to get across what I'm saying, I'd suggest a question. Why are sensors alone insufficient, right? I mean, after all, we could attach noise and air pollution sensors to things like delivery trucks and bikes, for example, right? I think the reason is that we need both raw inputs and subjective personal experiences to really make effective use of these, right? So if you think about the case of route planning, suggesting routes that people can move through a city, it would be hard to know what to suggest to people on a specific morning in terms of just numbers alone, what's happening on the street, right? But with experience reports, we can quickly detect whether or not there really are some routes that are experientially better than others, right? When we think about what's happening with COVID, with mitigation, containment efforts, we haven't even begun to deal with factors like fear, right? The question on everybody's mind for who knows how long moving forward is going to be, when is it safe for me to go outside, especially in places like New York City? And so bringing in that experiential piece, I think, is really essential. In all these cases, I think participation is really what's going to get us there. We academics and others, I think, can gain a place at the table with big tech and government if we can do so with the trust of citizens, right? We can form the safe harbor for data that can be leveraged for good. And I think the question for us, though, is how do we intervene, right? And at what level do we intervene? I think a lot of times, because we collect data from, say, a specific set of individuals, we feel like we need to intervene and help that specific set. But just like we use GPS to improve traffic apps that all of us benefit from, I think Pulse is an example of the way we can use these sophisticated technologies and experiential sensing systems to potentially benefit everybody, right? Improving and optimizing municipal efforts to mitigate these sort of potentially toxic factors in urban environments. So thanks a lot, everybody. That's all I've got.
Thank you, Tom. And last but not least, Fiona, your turn.
Hi, everyone from sunny west of Ireland. Thanks a million for the invitation, and just firstly to say congrats to Maria, Ricardo, Emmanuel, and everyone involved in the Pulse project. 2 days to go. I know it's very, across 6 cities, many people involved, so well done to everyone, and it's great to be part of this final workshop. My name is Fiona Donovan, and I work as part of the Healthy Cities and Counties, which with Elizabeth, and I'm based also in the Health Service Executive. So just the next slide there, Carolina. Thanks. So just like Joe, I suppose an overview of where we're at. This is Moore's Law, so it's a technology, but about healthcare, about stay left, shift left, and I think it's pretty self-explanatory. But if you see on the right-hand side of the screen, a lot of funding focus on acute care. If we move left, it's about moving to the highest quality of life. And I think that's why we're here today, and a lot of people, and I see that the Pulse and big data can help that. And that preventative and proactive healthcare, where we know it and people can see it, the balance, if you can see this, you know, it's quite tilted, and I see Pulse then, you know, and big data trying to focus it on that side. So you can see here I've highlighted monitoring and environment are two areas for that, and this is a great example of this, and in terms of the quality of care. So anything, like we know, and what Joe was saying, that the whole focus is on prevention, but I think we have to get better at tools and evidence, and to make that shift. And if you want to go to the next slide. So I suppose just on reflection, what I got out of this and doing background research is, I suppose, the focus and to make the intangible tangible. So this is what big data does, but it's not just that. You have to engage the citizens, you have to interpret it, and you have to translate that to real action. So I think it gives a focus. Visualization, I think, is really, really important, and well done on the app and just going through that and the analytics. So I think we know it, but I think that every opportunity we have to make it real is very valuable. And I suppose just the final comment is that I suppose the big challenge is health and all policies and, you know, whole of government. It's very easy to say it, but it's very hard to do it. And I think this is a great example of bringing environment departments, health, technology, bringing it all together. And the technology isn't the end in itself, but it's like the magnet to bring it together. And it's those intersections that we'll get good innovation, and that that really, that's what Pulse, it's very much that translating the concept into reality. So just well done to everyone involved. Thank you.
Thank you so much, Fiona, and thank you to all of you for being part of this. We have a few more minutes for questions and answers. So I heard many, I came across through many messages that I heard. One was listen, pay attention and listen, from Elizabeth. Make the untangible more tangible, and so on. And this whole issue of like to think about like the connection between health and healthcare. So one question that was posted by the audience, by someone from the audience, was, and that came across, is, when you have all this data, who owns the data, and how to think about who owns the data. I guess it matters in terms of not only how the data is used, but also it matters in terms of how much trust people put on that data. So it would be nice to hear reflections from you on that and how you have approached that in your own line of work. All of you, well, I'll start with Tom, since you're collecting a lot of data, and you're probably asked this question often, like, what are you going to do with all these pictures you're taking and all the data that you're collecting?
Yeah, the pictures, I can think of two. I'll try to make two quick comments on that. So my initial thought had to do with the role of consent in IRB, and I don't have to tell you all how things are evolving in the EU. I'm not an expert with some of the changes there, but you know, in the US, there's also a trend towards broadening what we consider potentially harmful research, you know, that needs to account for human subjects and consent and all of this. So when we think about consent in this specific question, we're often, one of the toughest questions is whether or not people have control over the data, right? So we can ask who owns it, right? A lot of times that's almost like proprietary in nature, and there's who has access to it, say, for the purpose of a study, but who controls the data moving forward, right? And does a person have the ability to retract their data, right? Are they giving you a blanket consent to hold on to their data forever? It can be just logistically challenging, right, to comply with data retractions, it also raises this last thing on this. It raises this difficult consent and IRB, almost philosophical issue. How can a person possibly be aware of? How can you possibly make them aware of every conceivable future concern they might have that would cause them to want to retract their data? You know, there's a lot of tricky questions there. The other one, Jose, I think has to do, I'll be quicker with this one. I think I've seen, and I would comment on, is the way academic, public and private type of organizations are going to contractually work with these different data sets. So for example, for one project in New York City, myself and some other colleagues are working with an automated car company in the city that has the ability to carry street view cameras on top of all of their car. They have a fleet of cars. It's called a swarm data collection strategy, where they're using delivery trucks that are naturally moving through the city to mount these cameras, because they need as a company, they need information about the environment to make their cars drive and not run into things, right? Well, we discovered that they had this data and it could be very useful for surveillance purposes. Now, the issue is that that company may need to retract their data, right? What happens when one of their cars kills somebody? And the new prospect for academia is, well, how do we deal with that? Like, you know, forever, we've been able to say, well, you're lucky to work with us and we're going to own the data and everything else. If we want access to basically the big data, right, whether or not it's from an automated car company or from an internet company or something like that, there's a new reality that we may need to rethink the way we engage and what we're willing to say about whether we own those images. And so I think this sort of push-pull of how to predict and how to retract potentially and so forth make this ownership question particularly thorny.
Thank you, Tom. And I wonder whether, Elizabeth, do you have any comments on, you mentioned that in Sweden, you know, you've been collecting data from the 1800s, so there may be more of a culture of like, here's data, maybe the data has value to people, and then people are more likely to, for example, participate in activities like this. So have you encountered any challenges in that sense? You know, given that we're talking now about new technologies and so on.
Yeah. Yes, definitely. I think, like Thomas says, this is a new debate that we need to have, because I mean, coming from this country, we trust our authorities, and we have done that since a long way back. But today, it's not really the authorities who has this kind of data. It's others. It's private companies and social media. But we are very, I mean, it's the cultural context, of course, if people trust the government and trust the public service or not. And in this country, we are very trustworthy. But I think we start now to discuss this, and we need to have a big discussion everywhere. Who owns my data? Who owns my picture? Who owns whatever I enter into Facebook or elsewhere? And I think this has just begun. And I think we need to have a continuous discussion around this, and what is the private integrity in this and what is not. And as soon as you start joining data from registers and my personal data, it gets very, very tricky. And of course, there is a common good in this. And I think during this pandemic, we all want the pandemic to stop. So we are eager to use our own personal data and put into the apps or whatever we have. But it could easily turn out into something completely different than a common good. And that is political decisions. And as we know, political decisions could be made very, very quickly in cases of crisis or whatever. So I think this is democracy that needs to be taken further, definitely.
Yeah. So thanks for those comments. You know, that's obviously a challenge of who owns, how the type of ownership has changed over time, and how that makes people rethink about how that information could be used. And you're not even thinking about how information is going to be used in the future when you provide that information today, and 10 years from now it could be used for something else. So who knows? Fiona, you've been involved in sort of like I would say health promotion in Ireland and so on. And do you have you encountered issues like this?
Not really. I suppose I agree with Elizabeth and Thomas that I suppose that it's kind of been a hidden, like data has been there and more kind of covert, and there's a lot of data out there. But just what Elizabeth says is that, and they're discussing this about, you know, the current situation, that people do want to provide information, and that balance between using data for good and where that data is going is a debate that's starting, I think, in Ireland as well. So so this is very interesting. But I think it is that balance of contributing for the greater good as well. Yeah.
Thank you. So I know Joe had to step out. That's why you don't see her on camera. And I had a set of questions for her, but that's okay. But more than anything, so I just have a few questions. Elizabeth, you've worked with different health networks, WHO, you have experience in sustainable development. How do you think technologies like this could be used to address health equity issues, which is something that actually came up in Carmen's talk earlier? She was showing COVID-19 data by neighborhoods and so on. So how do you think platforms like this can help with health equity?
Well, I have experienced myself how this could help locally, because using local data could easily show that there are differences. I mean, if you have regional data, if you have national data, it's more a median of what you can find. But if you have local data, if you look at local neighborhoods, you could easily find out the deprived areas, and you could easily see how different life expectancy is throughout the city. So, and showing that to local politicians and say, look, this is what your city looks like. It's of tremendous help to move forward for health equity. But I also would say that, I mean, with this kind of technology that we have today, and with people wanting to contribute with their own feelings and their own comments, I think it could be used for participatory processes and reaching out to vulnerable populations, reaching to children, reaching out to the elderly. If that could be made through this easy way of getting access to people's own thoughts and views, and using it as participatory processes in developing policies, it's a tremendous way forward. Yes. You can. I mean, usually it's the people who know how to write and talk who comes to meetings, but with this kind of new technology, you can reach everybody. So that could be
interesting. You mentioned that. I mean, in part because we've been thrown for the last month into this world where we always had excuses about how technology could not be used, or barriers or everything, and they're still there. Obviously, many people face those barriers, but it almost feels like the expression "sink or swim." You know.
Yeah.
You figured it out quickly, or you know, universities have gone from face to face to, you know, virtual. Everything has gone like that. So but I'm sure there's still folks out there that have difficulty accessing technology and so on. So I say
definitely. And we have to make the technology accessible, because it needs, I mean, the technology needs to develop so everybody can get access to it. Both in terms of,
The conversation, can you hear me? The conversation made me think of humanitarian disaster relief efforts. I'm a faculty advisor for the NYU Youth Mappers Club. If you don't know about Youth Mappers, it's an international consortium of student GIS clubs. More generally, humanitarian OpenStreetMap team, if you're not familiar with that, and just generally OpenStreetMap, which is an open source map of the world. Why do we need that? Well, Google and Bing and them own the maps most of us use. And just, I guess, comment on the shift. I know that there's been so much good work done through these open source humanitarian mapping efforts. Usually their utility lies in really developing nations, right, where you don't even have a map of where the hospitals are and what the distributed system is. It usually didn't seem necessary to think about using those tools to look at the healthcare systems in New York City, say, right? Well, now we have temporary facilities, tents going up, and the number of beds fluctuating. And, you know, we all of a sudden, you can see the way this distributed crowdsource, as others are pointing out, citizen types approaches could definitely be of huge utility for advocacy and just participation anywhere.
Thank you, Tom. So I'll finish with Fiona's comments, or I don't know if you have comments on this, or I can ask you questions which are basically connected to how do you engage. Well, I'll ask you the question: how do you engage citizens with all the tools that you know that we have mentioned here, including with what you saw in Pulse?
And I suppose just picking up what you said, Jose, I think if we were having this meeting a month ago, there'd be a lot more challenges. I think it's a different world and technology and how we can use it. How we engage it, I think that's the visualization. And I know on the Pulse system, which is really good, the rewards were like points and everything like that. But I think actually a big part of that is that feedback loop, that you contribute, something changes policy, it improves the air quality. And that's actually a huge reward in itself, that we don't need, you know, the points. So I think that that meaningful engagement and that feedback, that it is an engagement, it's a two-way process. I think that's hugely important, and that just, I suppose, bringing things together and making those interconnections between health, environment. We live in a complex, messy world. Our systems are often very linear. Departments are like this. We report back in Excel, but that we're okay, and we can get, we're good with complexity, and that big data and the likes of Pulse can help that.
Thank you so much, and I think I'll end with that then. Those comments. Thank you, Fiona. I'm very grateful for that you took the time to do this, and it's a nice way of wrap up a lot of work that has been going on how to integrate different pieces of data across countries, and many of the lessons learned through this journey that you've seen everybody go through. You got a little peek of it. I mean, the whole audience on that today, and I'm glad that happened. So I hope people enroll in the course that we have and so on Pulse. So I'll finish with that. Carolina, you want to take over now?
Perfect. Thank you so much, and thank you to all the panelists. So the virtual round of applause to all of you, and thank you, Jose, for moderating this panel. Thank you all for asking the questions, and again, thanks to all the panelists for great contribution, sharing with all of us your experience and your views on big data and the future of population health. Or actually today, like it was said, like still 1 month ago, it was a different word. The future is now. I'm sure that many of us can agree. We are going to the end of the day of this webinar, and I would like to ask Maria, our coordinator of the Pulse project, for the closing remarks.
Thank you, Carolina. Thank you, everybody. So we don't have that much time, but the first thing I would like to do is to thank all the audience and the external speakers for participating in this final event. We have presented to you today different achievements that Pulse project have accomplished in these more than 3 years of collaboration and working together. There are some points I have I want to make about the discussions that have taken place today. The first one is related to the work that we have carried out with the cities, because we chose cities as a recognition of the fact that the urbanization is the driver for public health risk addressed by this project. And from the different approaches that have been discussed today, it is clear that it is in cities where solutions can be found and the resilience can be scaled up. From many discussions, it's clear that data are used in large public healthcare systems to make decisions, and there is a clear need to align this data, the models, with the reality. We are in a society where individuals generate a lot of data, and the only way to which the data can be used must place interest on the individual first. Citizens, as you comment now in this panel, will trust this data-driven innovation only if they are confident that any personal data sharing will be subject to regulations and data protection rules. It's important that we use this for the engagement of the participants. We have used this participatory approach as commented by Fiona at the end. And I think that all these platforms and tools that Pulse have developed will help to connect with the leaders and the citizens. And we are really open to accept more communities and more cities to join this initiative. As was commented by Carolina, a last point is about our online course. Please, we really will be happy to have you participating in the course that will be available either tomorrow or the day after. Thank you again, and I leave the floor to Carolina or maybe Valentina if they want to close the event.
Yes, thank you so much, Maria, for closing. And yes, this is actually our end. So we would like to thank all speakers, panelists, attendees for making all happen. And thank you all of you for being with us today. And yeah, this is the end of this project, and this is the end of this online workshop. But of course, this is not the end of the international cooperation, not the end of the European and global exchange of ideas and innovations. As we all learn, there is so much to take from Pulse. And there was also like the one slide showed where it was actually said like, hey, here you have the continuation of Pulse. So and of course the work in the cities continues. So let's make it all happen. Now, if I might ask all our presenters and speakers to put their cameras on and to join us in this joint celebration of this international cooperation and exchange. And I will put us a bit of music to make us all happy and so thank you again.
Thank you very much, everybody. Thank you.
Thank you. Thank you.
Thank you.
Thank you.
So
Bye-bye.
we can now chill out with a bit of music. We don't have the sparkling wine or kava for the celebration, but the music will hopefully make it. So, and for all our attendees, as it was said, please follow our social media of the Pulse project and social media of the European Connected Health Alliance. All materials will be available, and yeah, join the online course. Thank you.
And thank you very much to the team. Thank you.
Thank you.
Bye.
Thank you for setting it up.
Bye.
Everyone.
Bye.
Well done, everyone.
Thank you. Bye bye. Great job.